Good evening, sir.
Good evening. Can you hear me?
Yes, sir. So can we start?
Another 1 minute, please.
Yes, sir. So good evening, one and all. I welcome you all to today's Navigate Medico CME program. Now, I would like to request Professor Umesh Kapil sir, the Secretary of National Academy of Medical Sciences, to provide his welcome address.
Namaskar and good evening to all of you, especially the participants who have joined for this important online program. I would like to welcome Professor Rakesh Chadda sir, who is our Chief Coordinator for a series of 6 lectures in the field of mental health. I would like to say that this is a very important area in which a lot of emphasis has been given not only by our country but also internationally by WHO and large number of other countries. Sir Chedda Sahab, we are most grateful to you for being with us and helping us and facilitating the Navigate program. My special thanks to Professor Pratap Sharan, who is the speaker for today, and he will be briefly mentioning about personality disorders. What we have is about 45 minutes of presentation.
He had the potential to handle multiple jobs at time. That he would become a millionaire soon because of his music.
Wait.
He wanted to open multiple.
Sir, you're on mute.
Professor Pratap Sharanji. Over to you, Preeti, for further proceedings. Dr.
Preeti, you're muted.
Thank you, sir. And I would like to invite Professor Rakesh Kumar Chadda, sir, who is a professor and head, Department of Psychiatry at AIIMS New Delhi, and also the chief of the National Drug Dependence Treatment Center at AIIMS New Delhi. He is the president-elect of World Association of Social Psychiatry, and he is also the Secretary General of World Association of Social Psychiatry. Chadda, sir, has been a recipient of many national and international awards, and he has been a honorary fellow of World Association of Social Psychiatry. He has more than 200 publications to his credit, including books, and he has worked in the area of somatization, caregiver burden in severe mental disorders, DART syndrome, and help-seeking behavior. And he is a distinguished international fellow of American Psychiatric Association. We are grateful to you, sir, for taking out your time and being the chief coordinators for today's session. I would like to invite Professor Chadda, sir, to give his valuable remarks regarding the CME sessions.
Thank you, Dr. Preeti, and good evening, ladies and gentlemen. First, I would like to say a few words. Especially, I would like to appreciate the initiative taken by the National Academy of Medical Sciences, especially the President, Dr. Shiv Sarin, then Secretary General, Dr. Umesh Kapil, for taking this very important initiative of starting the CMEs in various disciplines for the postgraduates and also other young psychiatrists. And in that background, we are having a series of 6 lectures on some of the very important clinical areas in psychiatry. And today we are starting with the first lecture that's on personality disorders, which will be taken up by Dr. Pratap Sharan, who's the best suited person in the country to take a lecture on this topic, the topic of personality disorders. Personality disorders, just to begin with, is a very unrecognized area in the clinical practice, especially in our country, though in the Western countries, it's one of the main focus in clinical practice because a large proportion of the patients who come in the clinical practice in psychiatry, they suffer from personality disorders. So, we often find difficulty in recognizing as well as managing the patients who present with personality disorders. Just to introduce Dr. Pratap Sharan. Dr. Pratap Sharan is currently professor of psychiatry at AIIMS New Delhi. He has been a professor in charge of student welfare services, student welfare center at the All India Institute of Medical Sciences. He has been a member WHO International Advisory Group for revision of ICD-10 personality, mental and behavioral disorders. Has been past president of Indian Association of Social Psychiatry and Indian Association for Child and Adolescent Mental Health. So he's widely worked in the area of mental health and different areas. And I hope the PGs and the other young psychiatrists who attend this program, they will be further enlightened on this area of the personality disorders. Thank you.
Thank you, sir. Over to you, sir. Pratap, sir.
Thank you, Preeti. I would like to thank NAMS, particularly Professor Sareen and Professor Umesh Kapil for giving me this opportunity, and Professor Rakesh Chadha for thinking me suitable to deliver this lecture. Dr. Preeti is the unable to.
You're not able to see your screen.
Is the screen visible now?
Yes, sir.
Okay, thank you. Okay, so dear participants, I will be talking about personality disorders. One of the reasons why we are talking about personality disorders today is that in ICD-11, there is a major change in the way personality disorders have been classified, and that will lead to significant changes in the way we are going to manage personality disorders. Before going further, I would like to acknowledge the help that I received from Dr. Nileshwar Das in preparing this lecture. Individuals with personality disorder represent a significant deviation from how an individual in a given culture perceives, thinks, feels, and particularly relates to others. So basically, a person who has a personality disorder is very different from other people. So the simplest way of understanding a personality disorder is that these people are different from average people. And different classificatory systems have tried to capture this difference in many ways. Like ICD-10 talks about deeply ingrained, enduring patterns of inner experience and behavior. So they think differently, they behave differently, and it manifests in inflexible responses to a broad range of personality social situations. So what happens with normal people is that they're flexible. So if let's say if they meet older people, they will be respectful. If they meet younger people, they will be affectionate. So their patterns change, while people with personality disorder tend to behave in the same way across various situations. DSM-5 has also talked about enduring patterns manifested in at least 2 of the 4 domains. And so they talked about cognition and emotions, but they have also specifically mentioned that there is problem in interpersonal functioning of personality disorders, and that they have significant difficulties with impulse control. When people have these kind of inflexible behaviors, they often will have subjective distress, and they will have problems in social functioning, and that's when a person is considered to have a disorder. The problems with personality functioning usually starts in childhood and adolescence, but because the earlier classificatory systems have kind of emphasized the enduring nature of the illness, usually the disorder is diagnosed after 18 years of age, but there is no classificatory restriction to diagnosing it earlier if the problems are very clear-cut. The importance of personality disorders is that it increases mortality and morbidity. The mortality goes up because of suicides, because of homicides, accidents, etc. But it also leads to a lot of problems in social areas. So there may be separation and divorces, there may be unemployment and poor work performance, there will be poor quality of life. And if people have other illnesses, whether mental illnesses or physical illnesses, the other illnesses are become difficult to treat because of the complication of personality disorder, which is often not recognized. And so these people may be poorly adherent to treatment. They lead to a lot of negativity in the part of treating physicians, and so it's difficult to get the treatment going. Historically, Charak talked about the Triguna theory, where he said that a man's prakriti is defined by the relative accentuation of one of the 3 gunas, which could be sattvic, rajasic, or tamasic. The issue here is that his conceptualization of personality is of an evaluative nature. So a person is good or bad, while the Western conceptualization of personality disorders is more descriptive. Like when Galen linked Hippocratic 4 humors to personality, these can be kind of linked with the 3 clusters in DSM. So it's more on a descriptive lines. Morel, Pinnell, and Koch in the late 18th century thought that personality disorders were mainly neurodegenerative disorders, and they kind of visualized it as either a beginning or a watered down version of psychotic illnesses. James Pritchard made the major kind of probably the most important conceptualization for personality disorder when he said that these are moral insanity. By moral insanity, he does not mean that this is a problem of morality. So moral insanity is not limited to ASPD. By moral insanity, he means that this condition is not primarily a kind of a physical condition, and this is not primarily a psychotic condition. This is not primarily a neurodegenerative condition. He thinks that this is a behavioral disorder, which is and that very clear-cut disease features may not be apparent. Schneider gave the first formal classification of PDs, and this has persisted to quite some extent till now. I'll show in the chart just next. But there are many problems with a categorical way of looking at personality disorders, and so we have moved to a more dimensional approach in ICD-11, and also future DSMs are likely to have dimensional approaches. If you look at the categories of Schneider and DSM-5, will see that some of these are, the terms may be different, but what is described under those terms are very similar. So the emotionally unstable of Schneider became borderline in DSM-5. What he called explosive is called antisocial currently. The self-seeking personalities are now called weak builder called dependent, and so on. It's And ICD-10 captures more or less the similar kind of a personality categorization. So ICD-10 has 8 specific personality categories, which are paranoid, schizoid, dissocial, or antisocial, emotionally unstable, which is of impulsive or borderline type, histrionic PD, and ancastic PD, which is obsessive compulsive type, anxious avoidant PD, and dependent PD. So these are very similar to DSM-5 and very similar to what Schneider had talked about. Apart from that, ICD also gives a category called mixed personality disorders, in which people can have features from various personality disorders, with none of them becoming clear. The enduring personality change can occur after traumatic events. So in current classificatory systems, there is this concept of complex PTSD, which captures this situation where people have PTSD alongside personality changes. The schizotypal disorder of personality disorder of DSM is categorized in ICD-10 under a rubric of schizotypal disorder. It's not considered a personality disorder in that sense, and it is under the F2 category. The narcissistic personality disorder of DSM-5 is kind of mentioned under the other specific personality disorders in ICD-10, and organic personality disorder is mentioned under organic conditions in F0 category. So personality problems are visualized over in very many different ways. DSM-5 has given 3 clusters: cluster A, which is odd eccentric; cluster B, which is dramatic; and cluster C, which is generally quieter. And the 10 categories are categorized within these clusters. As I mentioned, categorical classifications have many problems. So there is a lot of overlap. So a person will have features of paranoid as well as borderline as well as antisocial. And so what happens often is that and they may not have enough features of a particular personality disorder. So many people will have more than one diagnosis, and many people also will have not enough features to be given a definite diagnosis. So they will be called not otherwise specified personality disorder, not otherwise specified. Another major problem was the issue of overlap between personality disorders and axis 1 disorders like substance use disorder and mood disorder, which is partly because both ICD-10 and DSM-5 did not kind of give a detailed definition of what is personality functioning. So they talked about personality disorder, they talked about trait, but they did not really talk about when does one say that a person has a problem with personality functioning. And this will be, I'll discuss it later with ICD-11. Another very interesting finding that came up empirically was that while personality disorders were believed to be something which were very stable, they were supposed to last for decades, it was found that follow-up studies of 4 to 10 years showed that even over 4 years, about 50% of people with personality disorders no longer met the criteria for personality disorder. And over 10 years period, almost 80 to 90% of people would not meet the criteria for personality disorder. So this was something which was very unintuitive, and it suggested that there is a gross error in the way categories have been defined. As I mentioned, we are moving towards dimensional systems. So the first significant move was what is called the DSM currently uses the 3 cluster model for in section 1, which is their main classificatory system. But in section 3, they have given an alternative model, which they feel may be more valid. And they have said that more research should be done on this. And if it is found to be valid on research, they will move to the alternative system later on. But already a lot of research is happening on the alternative systems, probably more than what is happening on the classical system. In the alternative systems, the criteria A, they try to say what is the level of functioning. So the first thing that they're trying to get to know about a personality disorder is how severe is the problem. And for this, they have given a very definite a definition of what is personality functioning. So they say their problems will be in two areas: personality functioning in relation to self and personality functioning in relation to interpersonal dysfunction. So people can have either a poor sense of self-identity, or they may lack self-direction, so they may not be able to plan ahead. People may be very unempathic, or they may have difficulties in maintaining intimacy, either over short periods of time or over long periods of time. After one has decided that a person has a problem in personality functioning, then one tries to describe what is the kind of personality problem. And they have given 5 broad domains, which are very similar to the 5-factor model, or the Big 5 model that we talk about in psychology. So negative affectivity is very similar to neuroticism. Detachment is very similar to introversion. Antagonism is the opposite of agreeableness. Disinhibition is the opposite of conscientiousness. And all of us who have used EPQ, the Eysenck Personality Questionnaire, know about psychoticism. So they have considered that as the 5th major one. In the normal personality domain, the concept of openness is not reflected in the pathological areas. So that has been kept out. So they have given 5 broad domains. And within these 5 domains, for each of these domains, they have given 5 specific trait facets. Like, for example, negative affectivity has 5 trait facets. A couple of those are emotional ability and hostility. Criteria C, D, E, F, G are very similar to what were there in earlier diagnostic systems. So it talks about pervasiveness across situations, stability over time. One has to rule out alternative explanations like organic conditions, substance-related conditions, and primary psychiatric illnesses. ICD has simplified things even further because it aims to be utilized all over the world. So the idea was to give a very simple classification of personality disorder. So what it does is that it gives a classification based on dimension of severity. So the first thing one has to find out is there is a personality disorder, yes or no. After you have said that yes, there is a PD, one says that whether there is a mild personality disorder, a moderate personality disorder, or a severe personality disorder. And one could also say that a person has a personality difficulty, which is subsyndromal. So people with personality difficulty may need clinical attention, but they are not labeled as a illness. So it's the kind of thing that was earlier put under the Z category. So this classification is very similar to the ICD-10 depression classification, that depression present, then you say whether the person has a mild depression, moderate depression, or severe depression. So here it's something very similar that we are deciding whether a PD is present or not, and then labeling mild, moderate, severe. After that, to describe the personality, ICD has given 5 trait domain specifiers. So these are negative affectivity, detachment, dissociality, disinhibition, and ankastia. 4 of these are very similar to DSM-5. The disinhibition domain is not captured very well in DSM-5, but DSM-5 has a domain called psychoticism, which is not reflected in the ICD-11. So between the 2 of them, there are a total of 6 domains which could be assessed. Apart from that, because borderline pattern is a diagnosis which is very commonly used all over the world, and a lot of treatments have been developed around the borderline concept. So it was felt necessary to keep the borderline pattern in ICD-11 to help people with treatments and insurance claims. And so there were practical reasons for keeping the borderline pattern, so it has been retained. Amongst these 5 trait domains, one can give as many trait specifiers as are necessary. And usually what one sees is that as one moves from mild to severe PD, the number of traits keep on increasing. So very few people with severe personality disorder will have a problem in only one trait domain. It's quite likely that they will have a problem in 3 to 4 trait domains. So most people with severe PD, for example, will have very high neuroticism. They will have high dissociality and high disinhibition. detachment and anacastia may or may not be present with them, but 3 out of 5 are very common. Okay, so what are the clinical implications of personality disorders? One is that the all-cause mortality goes up by 3 to 4 times. Actual deaths due to unnatural deaths like suicide, homicide, and accidents increase by 10 to 20 times. And the life expectancy comes down by about 20 years, which is very similar to what we see with schizophrenia. So it's a severe condition, a problematic condition. Many of these problems are because of suicide and homicide, but people with personality disorders also have more cardiovascular diseases. They have, because of poor quality of care, they may have poorer outcomes for other illnesses. They may have comorbid psychiatric disorders and substance use disorder, which may add to the risk of morbidity and mortality. Often, if they have other conditions, comorbid conditions, they have poor treatment outcome because of poor adherence, difficult doctor-patient relationship, and less favorable response to treatment for comorbidity. Like, for example, if a person has borderline personality disorder along with depression, they are less likely to respond to antidepressants than a person without a personality disorder. There is an increased risk to self and others through accidents, self-harm, and homicide, physical abuse, marital discord, etc. The cost of care often is high because of hospitalization and frequent crisis situation, which leads to emergency visits. In terms of epidemiology, the World Mental Health Survey study on personality disorder showed that the point prevalence of all PDs put together is 6.1%. So it's not an uncommon condition. In most developed countries, the studies on PDs suggest that the rate are about 10 to 15%. So this 6.1% is a moderate estimate. It's possible that the estimates might actually be a bit higher. In this study, the lowest prevalence was found in Europe and the highest in the Americas. It was equally present across genders and ethnic groups. In clinical populations, however, the personality disorders are much more common. Like in primary care, about 25% of people will have personality problems. And in psychiatric outpatients, about 50% of people in the West at least seem to have personality problems. In Indian situation, the rates may be lower, but enough studies have not been conducted. I'll just come to that next. In the Western situation, more women seek help, and this may be because of the general tendency to help seeking, and also because of the repeated self-harm. So in young people, self-harm is more common in women. In legal and justice systems, up to 75% of people may have personality problems. So it is definitely a problematic condition. In India, there are very few epidemiological studies, and most of these studies have not focused on personality disorders. So they have not used any kind of rating scales or diagnostic interviews. So the findings are about the rates were about 1/10 of what was given in the WHO study. More recently, there have been some studies in special populations where the rates are much higher than what was reported earlier. Like a study from KGMC showed that in substance using populations, about 20% of people have personality disorder based on SCID-4. Similarly, a study done in psychiatric emergencies in Kolkata, where IPDE was used, showed that 24% of people with psychiatric emergencies have personality disorders. So the rates are not as low as what was felt earlier, but it may still be about half of what is reported in the West, because they're in the treatment-seeking population, the rates there are about 50%. We seem to have about 20 to 24%. There are many studies which suggest that genetic factors are important for personality disorders. Like when an adoptive study suggests that the cluster A has a kind of spectrum relationship with schizophrenia and psychotic disorders, and cluster B has a similar kind of spectrum relationship with substance use disorders. Molecular genetic studies have shown that various kinds of polymorphisms related to transporter genes, receptor genes, enzymes like catechol O methyltransferase and platelet MAO oxidase A are associated with personality disorders or with traits related to specific PDs. Gene environment interactions seem to be important. The environment of childhood maltreatment, poor parental warmth and emotional abuse particularly seems to be very important in the case of antisocial PD. And genome-wide association studies have shown that there is genetic overlap between borderline PD, mood disorders, and schizophrenia. These are some of the more specific findings. So what we find is that in cluster C patients, there are problems related to serotonin and dopamine. In cluster A people, there seems to be problems related to enzymes as well as calcium channels. And with cluster B, there seems to be problems with the serotonin system, the dopamine systems, various kind of channels. It doesn't mean that cluster B has more problems. It's probably because more studies have been done with cluster B. In terms of neuroimaging, there seems to be a problem with decreased cerebral volume as well as altered connectivity in schizotypal PD. Antisocial personality disorders have attracted more studies, and there seems to be a decrease in cerebral volume, particularly in the frontal area. fMRI shows decreased activation in the dorsolateral prefrontal cortex, and also decreased white matter fractional anisotropy in the corpus callosum. So they seem to have, on the whole, more problems with frontal lobe and its connections. Borderline PD people have problems in connectivity. An interesting finding was that a study which looked into DBT showed that there are some problems in fMRI prior to DBT, and after DBT, those problems became less. So there may be suggestions that psychotherapy may change the functional connectivity in brains. In narcissistic PD also, there seems to be more problems in the frontal lobe. Neurochemical findings suggest that there are dopaminergic problems as expected in the schizotypal personality disorder. Cluster B PDs have issues related to the enzymes related to the degradation of dopamine and norepinephrine. And ASPD particularly seems to have a broader spectrum of problems. But as I said, some of the reasons why more problems seem to be there in cluster B is because more studies have been done in that area. In terms of, there are multiple theories of why people may have personality disorders. Like cognitive theory suggests that PDs have a problem with pervasive self-perpetuating cognitive interpersonal cycles. So the problem there is that the way they kind of perceive and interpret relational cues, that seems to be problematic. Psychodynamic theory was, mainly this theory is by Kernberg. So he's talked about the importance of temperament, that some people are born with certain constitutional issues related to affective responses. So people who are born with this kind of problem of poor regulation or high lability of affective responses, when they meet with environments which are not very, which are complex, they tend to develop problems related to ego identity, ego structures, and ego functions. Like these particular issues about ego-related issues are very important in the definition of personality in ICD-11 and DSM-5 alternate system. Important theory was given by Benjamin 96 called interpersonal theory. What she talked about is that early childhood experience of relationship with attachment object leads to certain patterns of attachment in adult personality. So it seems that people carry internalized representation of important persons in their mind, and they respond to new people based on those representations. So if a person has had a kind of a secure attachment, they will carry a secure they kind of consider people as reliable. People who have insecure attachment, their concept of people per se is that they will be unreliable. So when they meet a new person, they kind of operate from this concept that this person is going to be unreliable, and it takes a lot of reliability on the part of the other person to make them comfortable. And when a person has this kind of a insecure attachment, for example, they find it difficult to accurately label their own emotions, and they are not able to see how other people visualize them. So they have problems with mentalization and in labeling their emotions. And the other major psychological impact seems to be that of childhood maltreatment and abuse, and longitudinal studies done over many years show that people who have had childhood abuse early in their life will have personality disorders later. The rates may go up by as much as 4 times. Clinical presentations, I think I'll move to. If we see paranoid personality disorder, they have excessive suspiciousness and distrust, because of which they tend to look at other people as deliberately demeaning, hateful, or threatening, or exploiting, or deceiving. So they expect negativity from other people. The rates are pretty high in the general population according to DSM-5. The comorbid PDs are other cluster A PDs, but they are also present in cluster B and cluster C. Cluster B and cluster C PDs may also occur alongside paranoid PD. In their complications, all PDs have high risk of depression, but paranoid PD also has the chance of brief reactive psychosis. Sometimes paranoid PD may kind of end up in a delusional disorder. A schizoid PD has a pervasive pattern of social detachment. So they have social detachment and emotional detachment. They do not want to connect with other people, and they don't experience and express a lot of emotions. The rates may be reasonably high in the general population. And again, they are comorbidity is high with cluster A, but also with avoidant personality disorder. They also may have brief reactive psychosis, but this is probably lesser than in paranoid PD. Schizoids may go on to develop delusional disorder or schizophrenia, but they are more likely compared to these disorders to have depression. So in that sense, their spectrum relationship with the schizophrenia spectrum is less strong as compared to paranoid and schizotypal PD. Schizotypal PD have social and interpersonal deficits, which are indicated by discomfort with and reduced capacity for close relationship. But apart from this, they have cognitive and perceptual distortions, which are different from other trait kind of. These are more symptom like they are symptomatic rather than trait-like features, because cognitive and perceptual distortions may occur sometimes like a trait, but often they also occur in episodes. It may not be present all the time. When they are very stressed, they may have these problems. When they're less stressed, they may have less of these problems. But they also have a lot of eccentric behaviors. In the general population, almost about 4% of people seem to have schizotypal features. Comorbidity is cluster A, but also avoidant PD and borderline personality disorder. And in terms of complications, they may have brief reactive psychosis much more frequently than other personality disorders. They are definitely on a spectrum relationship with schizophrenia, and a reasonable number of family studies seem to suggest that. Borderline personality disorder, I suppose all of you are much more aware of. It is about pervasive and excessive instability of affects. Their self-image is impaired. They have difficulty with interpersonal relationship, and they have marked impulsivity. In general population, about 2% of people seem to have a problem, but in clinical populations, they are overrepresented. It's more commonly diagnosed in women, and particularly in younger women. The reason why it may be more in younger people is that as people grow older, their borderline features become less. So by late 30s and early 40s, many people with borderline personality seem to settle down. it's the condition which is most comorbid with all personality disorders, including cluster B, but also with a lot of axis 1 disorders. So it's very commonly present with many other conditions. It, in terms of complications, again, it seems to have a relationship with a number of axis 1 disorder. It has a much greater chance of micropsychotic episode, almost similar to schizotypal PD in that sense. And people may have a lot of physical complications, and people with borderline PD have higher mortality than most other PDs. And these deaths usually occur in early years because BPD is, in that sense, more severe in the earlier years. Over 2 decades, they tend to improve. Antisocial personality disorder, patients have disregard for and violation of rights of others. The diagnosis is usually made after 18 years, but features should be present before 15, and DSM-5 says that they should have a diagnosable conduct disorder before 15 years of age. So this is something, if you're using DSM-5, you have to be aware of this requirement. The rate, according to DSM-5 in general population, is about 3% for males and 1% for females. And it may be more commonly present in low socioeconomic groups and in urban areas. Higher rates are seen in legal population in the legal system and in those with substance use disorders. In complications, it's often comorbid with externalizing problems like impulse control disorder, substance use disorder, pathological gambling. But equally, it seems to have a high rate of depression, anxiety, and somatization. And the mortality in antisocial personality disorder is higher as compared to most other PDs. It also tends to improve over 3 decades as people gain more experience and they face more adverse situations. Narcissistic PD is about pervasive sense of grandiosity. It's about either in their fantasy or in their actual behavior. They have a need for admiration. They lack empathy for others, and they're very envious of all other people if they make any kind of progress in life or have any achievements. According to DSM-5, this is a relatively uncommon condition at a PD level at least, and less than 1% seem to have, but in clinical populations, the rates are significant. The comorbidity is largely with cluster B, but also with paranoid PD in the sense that grandiose sense is known to occur in paranoid PD also. In terms of complications, many of them will have depression because when there is narcissistic injury, they tend to get depressed. Some of them will also want to have substance use disorder. Generally, people tend to get better after about 40 years of age, and get better from a narcissistic perspective, but many of them will develop depression around this time. People with histrionic personality self-dramatize, they have excessive emotionality, and they tend to be attention-seeking. In general population, about 2% of people have the condition, more common in clinical situations. Interesting finding reported by DSM-5 is that in general populations, it seems to be equally present across genders. Like in clinics, almost 9:1 ratio is women, but in general population, the rates seem to be equal across the genders. In terms of comorbid PDs, it's cluster B is common, but also dependent PD is seen as another comorbid condition. Many people with histrionicity will have depression, somatization, and conversion disorders. And they have a lot of interpersonal problems because they have shallow relationships. So they will have difficulties in marital areas. They may have to go in for suicidal gestures to get some attention to themselves. So it is a socially problematic condition. Obsessive compulsive personality disorder, they are preoccupied with orderliness, perfectionism, mental and interpersonal control. And the rates are pretty high in the general population, almost 2 to 8%. So it is probably one of the more common conditions in the general population. Rates in clinical populations may be comparatively less because they are somewhat functional, so they may not come for treatment. Most of the comorbid conditions are cluster C, and complications can be depression, anxiety. It is not very clear whether OCD is more common in OCPD or not, but some studies suggest that OCD may be more common. Another interesting finding is that they seem to have more of myocardial infarctions because they have type A personality features. People with avoidant PD have hypersensitivity to negative evaluation, so they kind of move away from relationships unless they are sure that they will be accepted. Because of this, they have social inhibition and they often have a feeling of inadequacy. The rates are about 1%. Comorbid conditions are more cluster A, but also cluster B as well as cluster C conditions. They have very often they will have mood and anxiety disorders, but a particular relationship is with social phobia, with which it shares a lot of features. Most people with avoidant PD will have shyness traits starting early in childhood. So compared to other PDs, it seems to have a direct continuity with early childhood. Most other PDs will have a continuity more with late childhood or early late childhood or adolescence. Dependent personality disorder patients they have the need to be taken care of, which leads to clinging behavior, and they tend to be submissive to the people that take care of them, and they will give up their own needs for these other people. So they become very dependent and they are scared of separation. The rates are about 0.5%. And again, interesting finding is that it's equal across genders. In clinical situations, mostly it's women who are diagnosed with dependent PD, but in general population, the rates are equal. Comorbid conditions are histrionic PD, anxious avoidant PD, and borderline PD. Many of them will have depression and anxiety, particularly when their dependency figure is moving away. So they will also have adjustment disorder, and some of them may have social phobia, but this may be linked to the fact that the comorbidity with avoidant PD is common. I'll now kind of touch on ICD-11 because this is important change that has occurred. So we may there may be issues related to that. People may find it a little difficult to apply ICD-11 initially. In certain ways, it's very simple. There is a 3-step process. All cases have to be looked at to see whether they have essential features of personality disorder. If yes or no. The second step is what is the severity of the personality disorder, whether it's mild, moderate, or severe. After that, after you have done this, you can stop. But in case you want to proceed further, then it's optional to give a trait domain specifier. So one or more of the trait domains have to be given. And again, if you want to give a diagnosis of borderline pattern, you can give a diagnosis based on if more than 5 out of 9 DSM-5 criteria are present. The essential features according to ICD-11 are there should be problems in personality functioning, and personality functioning is described as problems in functioning of the self and problems in interpersonal area. So a person may have a problem with self-identity as to who they are, like in borderline personality disorder. They may have problems with self-worth, for example, in anxious avoidant or dependent personality disorder. They may have a problem with accuracy of self-view, like in narcissistic personality, where they have a very grandiose self-view, or they have problems in self-direction as to how to plan ahead, like with antisocial people. Interpersonal dysfunction is about ability to develop and maintain close and, importantly, mutually satisfying relationship. So many people with personality disorder are not able to look in. They're not able to visualize what is happening with the other person. They have a very one-sided view of a relationship and what they need from it. People may not be able to understand other people's perspective, and when conflicts occur, they may not know how to handle those conflicts, because conflicts will occur in most interpersonal relationship, and most people have a flexible way of managing conflicts. It should be present for more than 2 years. It's manifest in a number of areas. And the important issue there is that when problems occur, it is problems related to inflexibility of behavior, or they have poorly regulated emotional expression or experience. So when we talk about cognition, emotion, and behavior, we are basically saying that there should be problems related to inflexibility or poor regulation in these areas. It should be manifest across a number of situations. Like adolescents, if they behave a little oddly, will not be considered to have personality disorder. If there is socio-political conflict, that will not be considered to be a personality disorder. People with PD should be diagnosed only if there is significant distress or significant impairment. In mild, moderate, and severe personality disorder, there are 3 main things to be looked at: whether the problem is discrete, diffuse, or whether it is kind of across all aspects of personality. So it's about the pervasiveness of the problem and whether certain areas of personality functions have been reasonably maintained. The second area is how they manage their functioning. So in terms of relationship and roles. So it could be that they are able to maintain some relationships and they can do some occupational roles in mild personality disorder, while in moderate, these roles are particularly compromised. And in severe personality disorder, they have very severe problems in all areas of personality and social functioning. The third major thing is the risk of harm to self and others. So mild PD people will not have much of this risk. People with moderate PD, the chances are that they will have a certain amount of harm-related behavior, but these are not likely to lead to long-term damage or danger to life. While people with severe PD are likely to have behaviors which might have already caused long-term damage or danger to life, or it's likely that it is. You kind of can predict that they will get into more severe problems. In trait domain specifiers, as I mentioned earlier, there is the 5 domains of negative affectivity, which is about tendency to experience a broad range of negative emotions, like they may feel suspicious, or they may feel sad, they may feel anxious, they may feel irritable. And most of the time, this will be out of proportion to the situation which has elicited it, and it suggests that they will have emotional ability and poor emotional regulation. They often tend to have negative attitude towards self, towards other people, and they have low self-esteem. In detachment, there are 2 main areas. One is social detachment, where they do not like to get close to other people, and the other is emotional detachment, wherein they are reserved and aloof, and they don't. If you ask them, they don't seem to experience much, and they definitely do not express much emotions. People who are dissocial disregard for rights and feelings of others, and they tend to be self-centered. So they act entitled, they want to be admired, they are attention-seeking, and they will always put their own needs ahead of other people. They also seem to lack empathy, so they don't mind hurting other if it furthers their cause. So they may be deceptive or exploitative or even ruthless. They could be mean and aggressive. So meanness is kind of verbal or aggression or psychological aggression. They could be callous to other people's suffering. People who are disinhibited tend to act rashly based on immediate stimuli, and they don't seem to consider the negative consequences. So common manifestations may be impulsivity, distractibility, irresponsibility, recklessness, or lack of planning. And in Castilla, the core feature is narrow focus on one's own rigid standard of perfection, and they try to ensure that everyone follows the same kind of standard. So they tend to be perfectionistic in terms of norms, attention to detail, routine, scheduling, organization, etc. And they also seem to have emotional and, importantly, behavioral constraints. So they want to not only keep a control over their own emotion, they also, because of their risk avoidance, they tend to be very perseverative and very deliberate. So they want to do things in a very controlled manner. People with borderline PD pattern, the diagnostic features are the same as in DSM-5. So there is this issue about efforts to avoid abandonment, unstable relationship. I will not go into these details because I suppose most of you would be aware of these. People with personality disorders can have issues where it becomes difficult to diagnose vis-a-vis other conditions. So I will be briefly touching upon the differential diagnostic issues with axis 1 disorders. I will not go into the differential diagnostic problems with other personality disorders, because if one understands why a particular problem is emerging in a personality disorder, one is able to kind of make out the difference between, like, for example, avoidant personality disorder and paranoid. Avoidant personality disorder is avoidant because of fear of embarrassment, while paranoid is because of fear of paranoid ideation. So if one gets adequate history, one is able to differentiate between these kind of conditions. People with paranoid personality disorder, if they develop psychotic conditions, then it becomes a little difficult to diagnose whether they have a psychotic disorder or schizophrenia. The differentiating feature in paranoid PD will be that any psychosis will be of short duration and it will frequently be associated with stress. So if these two features are present, then one may think that this is because of the personality disorder rather than a separate condition. People with schizoid PD, a major difficulty may be in differentiating from autism spectrum disorder. So ASD people have more severe impairment in social interactions. Schizoid PD seem like quiet people, while the oddities in ASD is more clear cut. They also have stereotypic behaviors and interests, which are kind of more inflexible as compared to what we would see in schizoid PD. Schizotypal PD, there can be a difficulty in differentiating it with communication disorders, which has been now kind of a new diagnosis in DSM-5. The issue with communication disorders is that their severity of language problem is much more, and they try to make efforts to communicate, while a person with schizotypal personality disorder is not interested in communicating. People with antisocial personality disorder can occasionally, there may be a differential diagnostic issue with bipolar disorder, manic type, but bipolar disorder is episodic and there is a sustained elated mood during the period, while the impulsivity or the reckless behavior or poor social judgment of antisocial personality people will be for shorter periods of time, and one can't see that sustained elation lasting over days or weeks. Narcissistic PD would, I think I won't go into these details. Okay. In avoidant personality disorder, major differentiation may have to be made with social phobia. But in social phobia, the avoidance of social contact is in specific situations. These people can get along with other. They may have long-term friends and they may be family members with whom they maintain contact in other situations. In fact, they may take help of other people in dealing with the situations where they have difficulty. People with panic disorder with agoraphobia, particularly those who are homebound, may sometimes resemble a person with avoidant PD. But in this situation, they are trying to avoid situations where help is not available, and they're quite happy to take help of people and move out if need be. A differentiation between OCD and OCPD can be somewhat difficult, particularly if people with OCD have somewhat egocentric symptoms, but classical cases of OCD, the obsessions and compulsions are ego dystonic, and that's the basis on which they can be differentiated. From a management perspective, the first thing about assessment is to do a clinical assessment in which one should look at the events. The best way of assessing personality is to look for how people have reacted to various events. So if you look at an event, you see their cognitions, their emotions, their behavior in relation to that. One can make out what is the reason why they behaved in a particular way, and that helps in labeling a trait more easily. And one needs not one event, but probably for each trait, one should have at least about 3 to 4 events. Then one knows that there is a pattern. One could use the DSM-5, ICD-10 or ICD-11 diagnostic classificatory descriptions to guide the exploration, because there are a number of features which need to be assessed. So sometimes it's difficult to remember all of it. There are a number of self-reported screening instruments. So there is something related to SCID-5. There is a screening personality questionnaire there. MCMI is something which is used commonly in many centers in India. IPD also has a screening questionnaire, but it is kind of linked more to DSM-4 and ICD-10. Semi-structured interviews, there is again a SCID-5 personality disorder interview, but there are some very small instruments like the quick personality assessment schedule and standardized assessment of personality, abbreviated scale. These take only about 10 minutes to administer. They cannot give a definite diagnosis, but they tell us whether a personality problem may be present or not. So like SAPAS has only 8 items for screening, and it can be administered in 2 minutes time. IPD is available in Hindi, and the full diagnostic assessment takes about 60 to 120 minutes. But it gives you a definitive diagnosis. For the newer classificatory systems in ICD-11, there are standardized assessments available both at the level of, but currently it doesn't have a diagnostic interview available. A diagnostic interview is being developed at this point of time. So till now, the features that the instruments that are available, they are screening instruments, and they are able to give us they operationalize the trait concept. So the personality inventory for ICD-11 operationalizes the trait concept, and SASPD is for screening of whether PD is present or not. For DSM-5, for the alternate system, there is a level of personality functioning scale, which is a self-report scale. And similarly, there is a structured clinical interview for DSM-5 AMDP, which can give a diagnostic labeling for the alternate system. There are some personality assessment scales which are assess personality pathology from other concepts, not the official classificatory system concept. So like the quick personality assessment schedule captures Tyrer's original concepts of personality disorder. The dimensional assessment of personality pathology is based on Dirichlet's concept of personality pathology dimensions. The Neo-PI and BFI are about normal personality, and temperament and character inventory again is about normal. It's a Cronenger's concept. When we are assessing personality disorder, we should also be assessing for psychiatric comorbidities. And particularly if you look at this slide, you can see that depressive disorder and generalized anxiety disorder are very common, and substance use disorder is very common in people with cluster B personality disorders. In terms of treatment, the important thing to remember is that the mainstay, the first line treatment is non-pharmacological. Various types of psychotherapies are efficacious. When doing psychotherapy with people with PD, one should focus on a few things, that the treatment should be long-term. So when you take up a patient, you should tell them that the therapy will last many months, probably about 2 years. It should be integrated with other surfaces. When you start a psychotherapy, there should be a theoretical concept in your mind as to how you're going to go about doing therapy, because if you tried some techniques on day one on cognitive, on the next day you're trying dynamic, on the third day you're trying dialectical behavior therapy, it's not likely to work well. So there has to be a consistency in the way you're approaching a patient. And I will be talking about a general approach in at the end of the psychotherapy slides, about 5 slides from now, which tells us about how we can go about being coherent without having to follow classical models. And all therapies for PDs have to take into account that patients will try to drop out now and then, or they may get into difficult conflictual relationship with you. So we have to work on maintaining a therapeutic relationship. So it's not that if a person drops, if you're dealing with PDs, it's not a good idea to think that if they come, it's fine. If they don't come, it's fine. Because if you have to treat them, you have to hold them. Psychotherapy for PDs in developing countries would have to be large, because we do not have trained manpower available with the classical approaches. So most of us will have to provide supportive therapy with simple cognitive behavioral approaches and lifestyle management. Psychodynamic therapy has level 1 evidence available, and it aims to increase a person's reflective capacity and their ability to understand their own emotions and interpersonal relationships. CBT tries to change the dysfunctional core beliefs. TBT, the first aim is to decrease self-harm. It tries to maintain compliance, gives a lot of skills to manage the person's emotions, and ultimately it aims to achieve transcendence. Some of the other methods like therapeutic community, cognitive analytic therapy, behavior therapy, and idotherapy have less strong evidence available. I'll go into about 4 classical models. Dialectical behavior therapy, the philosophy is that it incorporates dialectics about thinking about life itself and validation of a person into a treatment focused on skills. So there are 3 major components. One is to make people think about their existential issues as to what are their goals, what do they want to achieve, and so on. The second is to it believes that patients have been invalidated often, so it tries to give validation to people in terms of their emotions and the way they feel, and it also provides them a lot of skills to manage certain things. So they believe that BPD is a result of transaction between individuals who are born with high emotional sensitivity, but who have been in invalidating environment. So if people who are born with high sensitivity but were in validating environment will not turn out to have BPD, but if they are in invalidating environments, they will end up with BPD. So there is a possibility that in India BPDs may be a little less than in West, because we have strongly intact families till now. What they try to achieve is that they believe that individuals can become more effective in managing their sensitivity through acquisition of skills that enhance mindfulness. So if they become more mindful, they are able to tolerate distress better, they are able to regulate their emotions, and they are able to manage relationships, particularly if mindfulness is combined with skill enhancement. It's an elaborate treatment. So there are weekly individual therapy, there is a weekly group skills training. People can approach their therapist through certain mobile numbers, and the therapists have to kind of sit in consultation teams where their own emotions are looked into as to whether they're burning out or not, and whether they are applying the techniques correctly or not. So it's an elaborate process. Mentalization based therapy looks into the mentalization refers to complex capacity that human beings develop as they grow to imagine the thoughts and feelings in one's own, but also in other people's mind. So they're able to mentalize what is happening in my mind, what is happening in the other person's mind. And the treatment basically tries to, it believes that personality disorders happen when patient stops mentalizing. They kind of believe that other people have fixed motives. Instead of thinking that people may be flexible, they feel that other persons are going to behave in a particular ways and not according to situations. And because of this, they are not able to take the influence of reality into account. So if you can see that people will behave differently in different situations, then you will look at reality. But if you think that they will behave in the same way, then you are not really looking at what situation is there. You expect them to behave in the same way. And since they are not able to understand their own minds, they also have to act before they kind of know that this is what they're feeling. So sometimes a person has to cut themselves to know that they are paining emotionally. in the other issue with with the MBT is that they believe that attachment interactions will when people are attaching, they become their feelings become hyperactivated. When they're away from people, they are kind of in a quiescent state. When they come into relationships, all these problems kind of become very active, and because of this, there will be problems in the therapeutic process also. So whenever there is a relationship developing, the problems kind of become more active. What they try to do is to stabilize the problem by strengthening the patient's capacity to mentalize, particularly under the stress of attachment activation. So it's when they are relating to us, the kind of problems that they develop while relating to us are the one of the major areas where the work happens. So one tries to make them understand, as to suppose you kind of arrived late by 5 minutes, and the patient tells you that you are purposefully trying to ignore him. You have to help them understand that this is because of certain other reasons, and there are so many situations in which you have been very consistent, for example. So some of the work is based on what is happening in the session, and some of it will be based on what is happening with other relationships. It again is a complex treatment, because there are weekly individual sessions, there are weekly group therapy sessions, and there is a reflecting team meeting. So in many ways, the structures are similar to DBT. Transference focused psychotherapy is kind of outcome of Kernberg's approach, who has talked about identity diffusion, primitive defense mechanism, unstable reality testing, conflicted internal working models of relationship, etc. They try to focus on problematic interpersonal dynamics in the patient's life, which results in intense emotional states. So mentalizing based therapy and transference focused psychotherapy, they share certain kind of features. TFT also believes that patients' inherent interpersonal dynamic emerges in interaction with therapists in their transference. So they are even more oriented that problematic dynamics will come up during the transference, and they jointly examine and resolve the splits between good and bad that drive instability in affects and relationships. So it's like DBT is kind of focused a bit more on people's lived lives outside of therapy. Mentalizing therapies kind of take care of both these things, and trauma focus, the focus is in transference focus, the focus is much more on what is happening during the therapy itself, and the relationship between the patient and the therapist. This is intense in a different way, that there are at least 2 individual therapy sessions per week, but there is no group therapy. So in the other forms, there is 1 group and 1 individual. Here, there are 2 individual sessions, and clinicians are encouraged to receive supervision, but they may not. So the group for clinicians is not a must in this. A new therapy which is emerging is schema-focused therapy. It is coming from the CBT stable, and it follows integrative cognitive work on trying to bring about changes, the schematic changes in the person's personality. They use a variety of behavioral, cognitive, and experiential techniques, and they focus on the therapeutic relationship, but also on daily life outside of therapy, and particularly on past traumatic experiences. So it's kind of more broad-based. Unlike the neutral stance of other therapies, SFT encourages an attachment between therapist and client, a partial attachment, a process called limited reparenting. So in a way, one tries to guide people in doing better. The therapy focuses on 4 schema modes. So if you have kind of read about transactional analysis, you will see certain similarities. So there are 2 schema modes about others, where they feel that the other person is a detached protector, or which is a slightly neglecting protector, or the other person is a punitive parent. So parents are seen as either detached and absent, or they're seen as punitive, not as warm and present. And there are two child modes. One child mode is about abandoned or abused child, and the other is about an angry, impulsive child. So angry, impulsive child is a bad child, and abandoned, abused child is a child who has who may be a good child, but one who is not kind of worth looking at. This also has 2 weekly individual therapy sessions. What I would want all of you to focus on is the general psychiatric management, because this is also found to be evidence-based and it seems to work well. And there are leaders of psychotherapy who suggest that this works probably definitely better than placebo, maybe almost as well as the more specific therapies. This has come out of the fact that there is significant problem of training and clinical resources all over the world. Even developed countries do not have enough psychotherapists to take care of all personality problems. So it follows a case management model where the focus is on patient's life outside treatment, unlike the more specific therapies, and interventions are more common sense. It prioritizes stable vocational functioning over romantic relationships. So you tell people that you should stabilize themselves in individual vocations rather than try to first build a relationship, because relationships are dual and they tend to be more likely to have problems, in the sense that one can work more consistently than like if a person relates very quickly with someone else, it is possible that the other person may be unstable and that can lead to problems. So they try to stabilize vocational functioning, and it tries to improve social functioning over specific symptoms. So the focus is not so much that they should be feeling better at all times. If they start functioning better, it is expected that over time they will start feeling better. It requires that you give the diagnosis to the person, because otherwise it's difficult for a person to engage in a treatment over a long period of time. So that the diagnostic disclosure should happen. Patient should be psychoeducated about what their condition is, what kind of treatment is going to be. And particularly it needs to be emphasized that PDs have a positive prognosis. Almost 50% of them will get better over a few years' time, and almost 90% of them will get better over 10 years' time. So this is something which has to be emphasized because it helps in people coming for treatment. It is multimodal, so many of us will be giving medicines, but we will be coordinating provision of group and family therapy. One has to follow up with the therapists if they're someone else to see what is happening there, and whether one needs to coordinate between the therapist and the people who are giving medicines. Here we are kind of working to facilitate the natural course of disorder. Most PTs will tend to get better. So like if we leave them, they may get better in 10 years. If we work with them, they may get better in 2 to 3 years. So that is what you are trying to achieve. It focuses on interpersonal hypersensitivity, because that is common to all PDs. And but like if one sees that there is a situation when a person has been hypersensitive to interpersonal situation, one works with the patient on that to see whether how their one is trying to say that your emotions have become dysregulated because you have been hypersensitive in this situation, or that you have involved in impulsive and self-harming behavior because you were hypersensitive to the situation. If you looked at it more calmly, this may not have happened. And then let's see how to go about working on that. Usually the package will be 1 weekly individual appointment. So this is less intensive in that way. In pharmacotherapy, it's not routinely advised. Usually one is trying to treat specific symptoms, or one is trying to manage crisis. Like suppose there is a significant dissociation or there is significant psychotic symptoms, then one may give it for short periods of time. Or if there is panic attacks occurring frequently, then one may give medicine for a short period of time. The other major reason why one gives pharmacotherapy is to take care of coexisting psychiatric disorders. There's limited evidence available of on these medicines for PD purposes, even though they will obviously be useful for coexisting psychiatric illnesses. So antidepressants take care of what they're expected to, but they also decrease mood swings, impulsive behavior, and suicidality. Mood stabilizers similarly may reduce mood swings, substance use, and aggression. Lithium particularly may be useful in this situation. Antipsychotics will be useful for psychotic conditions, mood swings, aggression, and sleep disturbances. and anxiolytics for anxiety symptoms. But important thing to remember about benzodiazepines particularly is that they may be habit forming. And the second thing is that benzodiazepines sometimes paradoxically increase impulsivity. So one should not use it commonly. So if you know that in a particular patient, they work well without paradoxical increase in impulsivity, they can be given. But with new patients, you should be careful about benzodiazepines. If we look at the medicines specifically, then escitalopram and sertraline seem to have good evidence, and they have strong recommendations according to various guidelines. Olanzapine seems to have a strong recommendation and good level of evidence. But there are other medicines which can be used, and you can recognize that most of these are the ones that we use routinely. So escitalopram, sertraline, mirtazapine, and then mood stabilizers like lamotrigine, topiramate, and valproate, and second generation antipsychotics starting from olanzapine, aripiprazole, risperidone, and quetiapine. All of them have some level of evidence available. When you are using medicines, there are certain things to remember that these are adjunct. One should take the decision of starting and maintaining treatment based on collaborative decisions, because medicines are not first-line treatment. So one should, the patients as well as you should be aware as to why you are using it. One should do a risk-benefit analysis because they have limited benefit and they can have harmful side effects. We should monitor closely for side effects. One should consider the lowest possible dose of these medicines. One should avoid polypharmacy. One should be aware of the risk of prescription medication overdose, because these people with personality disorders have a high risk of self-harm and suicidal behaviors. And one should be aware of the local medico-legal atmosphere. Like in telemedicines, one can't prescribe benzodiazepine, for example. So, and also if something happens because of your prescription, then you are liable judicially, that you should be aware of. In conclusion, PDs are associated with high mortality and morbidity. Various psychotherapeutic, various treatment approaches improve their quality of life. Managing the psychiatric comorbidity is important. Psychological interventions are the first line treatment option for all PDs. DBT particularly has shown good response in borderline personality disorder. Focus of general treatment approaches should be on treatment adherence and lifestyle modification. And one should remember that pharmacotherapies address specific symptoms like mood swings and aggression, and that they are not kind of capable of taking care of all the problems that people with personality disorders have. So they shouldn't be used as the single mode of therapy. So I suppose for most of us would be approaching dinner time, so I wouldn't like, I would like to stop here.
Thank you, Dr. Sharon. This is a wonderful lecture covering all aspects of personality disorders in just 75 minutes. Clinical presentation, etiology, biological aspects, management, assessment, so many things. So we can open the presentation for question and answers. I think Dr. Preeti can regulate. There are questions in the chat box.
Yes, sir.
Yeah, please.
Okay, sir. Thank you, sir. So the first question is from Dr. Gurvinder Pal Singh from AIIMS Bathinda. He has asked, what are the reasons for low robust Indian data about personality disorders?
The main reason is that to do a personality disorder assessment and get definite diagnosis, one will have to have apply the semi-structured interview schedules. So in general population, the National Mental Health Survey is the kind of the first nationally representative data set, I suppose. And that also did not, the NMHS uses the mini rather than something like SKID or SCAN. So in India, it's difficult to train enough number of people to, you would need either lay interview. if you use lay interviews, you will have to train them in how to assess a personality disorder before you can send them into the field. There are not enough clinicians probably to be able to carry out large-sized epidemiological studies. On the other hand, applying screening instruments tend to overdiagnose personality disorders by 2 to 3 times. So one would get a very, very kind of false idea about how much of personality disorder is present. But it's time that some studies at least were done. So the reason is that it's more time consuming to do personality disorder assessment, but it doesn't mean that we shouldn't do it because it's a common enough condition. And some of the studies which have recently been done in specific populations seem to show that the rates are high enough that it requires care.
Thank you, sir. Another question is from Dr. Anushka. After we have made our diagnosis of personality disorder, at least during the initial sessions, do we tell patients that they have a mental illness, or how should we go about it? If we say it is an illness, they may not take accountability for it. And if we say it's a personality issue, they may be offended by it.
Like if you can approach it a bit more diplomatically, in the sense that if you don't want to give a diagnosis on day one, you may wait for it. But if you want to take care of a particular kind, like suppose you want to take care of emotional instability, poor emotional regulation, if you want to take care of their interpersonal difficulties, one will have to give it a label. It's not possible to treat for personality disorder for, again, the therapy is supposed to last for about 2 years time. So how will you engage a person if you don't give a diagnosis? So at some point of time, we have to give a diagnosis. Normally, the term that I use is personality pathology rather than personality disorder. I tell them these are the specific features that are problematic and these are the things that I'm going to look at. So it's not one label. It is, I'm telling them that there are problems in the way you are functioning in your interpersonal areas, in your emotional areas, in the way, the kind of impulsivity that you're showing. And then based on that, one tries to say that these are the things that we need to do around it. And often I find that after a couple of sessions, once you have used the term personality pathology, they will come and ask you that, do I have a personality disorder? And then you can tell them, yes, this can be called a personality disorder in diagnostic systems. So labels will have to be given at some point, maybe not the first session, but somewhere along there.
So the second question, are there subtle differences in how males and female patients present with borderline personality disorder? Male patients oftentimes get labeled as narcissistic or antisocial personality disorder.
See, as far as the diagnosis is concerned, one has to follow the diagnostic system. So if a person meets the criterion for borderline PD, they will get a diagnosis. They cannot be, based on those criteria, one can't call them narcissistic PD. What may be true is that more women may present with borderline features because of whatever reasons. So it may be biological, it may be psychological, it may be social. But if borderline features are present, male will also be called a borderline PD, if a female will also be called a borderline PD. The prevalences may be different though.
So the third question from the same doctor. In today's day and age with social media, there is more of impulsivity, lack of real social interactions, which leads to some amount of feelings of emptiness, especially in adolescents and early 20s patients. Should we give them a diagnosis or observe over time, and how to proceed?
See, as time is over the years, as a kind of a cohort effect or as a secular trend, it's possible that personality disorder rates may go up. So if you have doubts about adolescents, like one of the criteria for all classificatory system is that if you feel that it's a developmental issue, that a person is likely to outgrow it by themselves in a short period of time, then you will not give it a label. So this will be a judgment call as to what is the severity of the problem, what is the persistence, how frequently the person is expressing the problem, and based on that, the diagnosis will be given. So if you feel that because of the social media, he is not really meeting the requirement of PT diagnosis, one can wait. One doesn't have to necessarily give a diagnosis initially.
A question from Dr. Asra. What are good resources, either books or video channels or apps for residents for studying psychology?
I could give some of these references to Dr. Preeti, who could probably send it over.
Fine, sir. Again, another question from Dr. Anushka. Sir, I would also like to learn from your wealth of knowledge about how to deal with counter-transference towards patients with personality disorder, especially cluster B patients.
Although it's difficult to answer this question in a session like this. This is something where clinical supervision would be required. So if you come with specific problems, then one can, this requires clinical supervision. This cannot be answered per se. Except I will make two comments about it. One is that countertransference is ubiquitous. With all patients with personality problems, you will have certain feelings which are conscious, and there are certain feelings which will come up unconsciously. So one should not be kind of ashamed that I have countertransference. All of us will have countertransference. The second thing is that if one is aware of this possibility of countertransference, one should be analyzing oneself. And if countertransference is coming up, it's a good idea to talk to a supervisor or a peer who's well placed to handle difficult situations. So as a general strategy, talk to a supervisor or a peer. And be aware. The most important thing is to be aware that countertransferences occur, and the second is to take help from. Like if you see all the classical psychotherapies, almost all of them say that you should be attending groups or you should be talking to supervisor, even if you're very well trained in therapy. So this is not something which is only about novices; it's about all people.
Question from Dr. Anil. Thanks, it was really informative and insightful lecture. I have few questions mainly related to complex PTSD and borderline personality disorder. As in complex PTSD, enduring personality changes also occurs, and as per ICD-11, borderline personality disorder features are present in complex PTSD. So how to differentiate complex PTSD from borderline personality disorder?
ICD 11, when it talks about differential diagnosis in its text, it mentions that if a person has complex PTSD, you need not give another PD diagnosis. So CPTSD trumps all other diagnoses. But suppose a person has CPTSD and a definitive another PD diagnosis. Let's say that a person with complex PTSD has a very definitive antisocial personality disorder also. Then you have the possibility of giving a second diagnosis. But most of the times, I think you will not need to give a BPT diagnosis if the problem started after the trauma occurred. If BPT was already present from before, then you might give a double diagnosis.
What is the natural course of complex PTSD? Is it similar to personality disorders?
There's very little literature available on it, but it may not be similar to PDs in the sense that most problematic PDs seem to get better over 2 decades time. With CPTSD, we don't really know what will happen, but it's possible that it may be worse.
Is there a difference in psychological trauma history in complex PTSD and borderline personality disorder? Since borderline personality disorder is also linked with psychological trauma or adverse life events.
See, this question is difficult to answer because of the methodology of the studies, the way they have been conducted. Like in CPTSD, people have started from the concept of trauma, that they have severe trauma, multiple trauma over a long period of time. So, and then, so the trauma history is much more clearly present in studies which have looked at CPTSD. On the other hand, borderline personality disorder studies have moved in a retrospective way largely, that they have looked at the borderline personality disorder first, and then they have gone retrospectively into whether trauma is present or not. So the link between BPD and trauma is less sharp than what it is between CPTSD's personality problems. So the answer to the question is that at present, trauma is much more clearly linked with CPTSD than with BPD, but this may be something to do with the methodology of studies rather than the reality of the situation.
So one more question by Dr. Anil is, what is the prevalence of complex PTSD in general population and clinical population in India?
In India, there is no data. Even in general, PTSD is very rarely diagnosed in India for some reason. It's not clear why. And there are no, like all the major epidemiological studies have not looked at PTSD. So we do not even have data on PTSD from a general population perspective. There's nothing on CPTSD.
Question from Dr. Sagun. It's a great presentation. Do patients with borderline personality disorder ever present with symptoms like delusions and hallucinations?
For short periods of time, they can. So those are called quasi-psychotic episode or brief psychotic episodes. Usually these occur under stressful situations, and they would typically last a few hours to a few days time, maybe up to a week's time.
Dr. Aizazbad has requested, kindly throw a light on oxcarbazepine and borderline personality disorder.
I mentioned that the mood stabilizers can be used. Evidence on some of them is more robust. On oxcarbazepine, till now, there is not enough evidence, but there's no particular reason why it will not work. The issue is that there is not enough evidence to kind of tell people to start using it. So if you want to use it, maybe you should do a study on it, publish it, and then think about using it, or wait for data to come up.
So one more question from Dr. Sarath Philip. I had a query with regard to how to understand the construct of insight for those with personality disorder. Would it be different for different clusters? Also, sir, how about pathoclistic effects of mental illnesses accounted for within our correct understanding? I don't understand what is pathoclistic.
It's pathoplastic, probably. The construct of insight for different clusters, I don't think it will be. I have to extend myself and give my answer. This is not something which is discussed in the literature per se. See, the way insight is defined in classical psychiatry, that grade 1 to grade 5 insight kind of a thing, that in that sense, the insight labeling would not be different for different clusters. But if you look at insight from a dynamic perspective as to whether people can understand their the way they are behaving, the way they are looking at things, most likely cluster C people will be able to have a more deeper psychological insight into their functioning as compared to cluster B, and cluster B will have a deeper insight as compared to cluster A. Cluster A, it would be very difficult to engage them in a kind of a therapeutic relationship where they could have insights into their personality functioning. About pathoplastic effect of mental illnesses, I think the current move is more towards seeing them as comorbidities rather than thinking that depression has this issue is more important from an assessment perspective. Like if a person, for example, has appears to have a personality problem when they have an axis 1 disorder, then it is recommended that one should wait and assess them again after the axis 1 symptoms have reduced substantially to see whether what appears to be a problematic personality remains or not. So the pathoplastic effect basically is that you have to probably treat the axis 1 problem and see whether the personality functioning is still problematic or not before giving a label.
A question by Dr. Janani. My doubt is on organic, which is post-head injury personality disorder. How do we manage it, sir? Does it settle on its own in 10 years like personality disorder? Could you throw a light on it?
There's no particular reason why it should settle on its own like non-primary personality disorders. It will obviously follow the pattern of the organic problem to a greater degree. So if there is severe head injury, it's likely that it will not improve much. If the organic substrate from which it is emerging improves, then probably it will get better. But it will not follow the pattern of primary personality disorders.
Question by Dr. Pankaj. I want to know that do we have any institute in India which provides specific training on structured psychotherapy, any diploma or certificate course, especially in DBT?
There is no kind of training institution like which gives a specific course on structured psychotherapy, but there are many centers now which are connecting with international agencies, and they're running short courses on structured psychotherapy, usually lasting for up to a month or so. So, but most of these courses are being run by private institutions. Like, for example, some will be connecting with the Beck Institution, some will be connecting with Linehan's group. So these are not full therapies. These are kind of you get exposure to what is done in those training. You will not get a complete training from Indian centers right now. One thing which has opened up recently is that some of the Western institutions have started giving therapy courses which you can join from India. So you do most of the training from India, and you will get supervised. You can get supervision from them, but you will have to look around for that. And usually these courses become very expensive because you have to pay in Western currencies usually.
Another question by Dr. Sagun. Sir, in girls, especially in borderline personality, how to rule out other comorbid psychiatric disorder because there is suggestibility?
I thought suggestibility was a thing of the past for girls. Suggestibility could be an issue with anyone. It could be with girls. It could be with boys also, particularly with younger people. So the way to go about doing it is to kind of assess more, in the sense that you may have to give them counter suggestions and see what they're talking about. So it's basically about deeper assessments rather than a problem per se.
I think there are no more questions as of now, sir.
That's great. So I'm supposed to do some feedback kind of a thing?
I think would be good.
So I was not very clear about how to go about feedback. So what I have done, I have not prepared MCQs. I have prepared case vignettes. So I can show 3 case vignettes. If they are volunteers, maybe they could give us their assessment.
Yeah. I think that's a good idea. So you can proceed. So
do we have any volunteers? Basically, what I want people to do is to look into the case vignette and give a ICD-11 diagnosis, because that's a new diagnosis. It's a new set of criteria that has come up. So you have to just to try to give a diagnosis. There is nothing like a right or wrong answer. We will be discussing it as we get along. So I'll show 3 vignettes. So case 1 is a 29-year-old woman she has made numerous suicide attempts, resulting in repeated hospitalizations. She has aggressive and impulsive behavior, and this has resulted in a loss of all reliable friends. Under stress, she tends to go into dissociative states, depersonalization, and psychotic-like voices telling her to punish herself. With setbacks, she has a lot of self-loathing or anger. She has excessive mistrust of others, compromised ability for intimacy and empathy. Occasionally uses ingratiation. She tries to be very um, ultra grateful, and she tries to be very charming to get warmth and approval from other people. She says she has no idea what to do with her life and what she has to offer to the world. There have been multiple treatment attempts with little benefit. She uses substances. She has eating disorder and panic attacks. And there is a prior history of physical and verbal abuse and sexual abuse. So according to ICD-11, what will be her diagnosis? The traditional systems, she will probably be very close to borderline personality. But based on ICD-11, what would you want, how would you like to assess the diagnosis in her case? Preeti, could there be any volunteer?
So there have been some comments
Okay.
in the
Yeah.
chat.
So Dr. Shagun says borderline personality disorder. So that is the classical way of looking at it. And okay. So severe PD and borderline pattern, negative affectivity and disinhibition. Severe PD disinhibition. Okay. So I think all of you have done. Okay. So this person has severe personality disorder because she has serious difficulty with regulation of emotional experience, self-esteem, and impulse. So these are issues related to the self pathology with risk of severe harm to self, psychotic-like perceptions, and lack of reliable friends. So there are problems related to interpersonal relationships also. She has high negative affectivity in terms of experiencing negative emotions that are out of proportion to situation, including shame, mistrustful, and anger. She has disinhibition, tendency to act impulsively in response to immediate stimuli in a harmful manner. A certain degree of dissociality, mistrust-related aggression, and tendency to manipulate or seduce others. So this manipulate and seduce is that tendency to the lack of empathy and using exploitativeness to gain one's own ends. And she will meet the borderline personality qualifier. So almost all of you have given this definitely, which is what ICD wants at the minimum, that you should be able to say that there is PD and there is severe PD. At the trait level, some of you have mentioned negative affectivity, some of you have mentioned disinhibition, but you did not seem to pick up dissociality because I think we tend not to pick up narcissistic pathology as dissocial. But according to ICD-11 dissociality or even DSM-5 antisociality now, narcissism as well as antisocial dissociality will be in the same group. And the borderline, obviously, you have picked up. The reason we are not calling it moderate personality disorder is that she is unable to maintain any friendships or a regular job, and her self-injuries have endangered her life. Okay, so case presentation 2 is a 36-year-old man. He suffers from loneliness and insecurity, poor self-worth, and self-defeating behavior, such as letting peers take advantage of him. He is anxious, shy, and he feels unaccepted amongst peers. He is socially withdrawn, avoids intimacy in order not to feel criticized, ashamed, or rejected. But he maintains a permanent job and a couple of relationships. He is intelligent, but he could not finish the college degree because of his self-worth issues. He has some panic attacks and depressive episodes. He has history of emotional and physical neglect with some emotional abuse. So let's see. A mild PD with negative affectivity. moderate, anxious, avoidant. Anyone else would want to give in some suggestions? Moderate with detachment. Okay, good.
So we have one more response, mild avoidant.
Okay, the problem is that, yeah. So here, as most of you have said, it's mild personality disorder because he has some distortion in interpersonal appraisal, difficulty maintaining positive self-esteem. He is highly submissive in relationship, but has some healthy relationship and has maintained occupational roles. So there is problems with interpersonal as well as self-related issues, but they are at a mild level and they are restricted. Negative affectivity because he has anxiety, shame, low self-esteem, vulnerability, and depressivity, and detachment because of avoidance of social interaction. So between the two or three of you, if you consulted each other, you will get all the elements right. Moderate personality disorder is ruled out because he maintains a stable job and a couple of relationships. So some parts of his functioning personality seems to be functioning all right. So case 3, 53-year-old man preoccupied with order, details, rules, and organization, reluctant to collaborate with others or to delegate unless they did it his way, excessively pedantic and stubborn. He has a right solution for everything and he feels that other people can't get the same level of accuracy. He feels important and entitled. He turns hostile when not recognized. And he has left several companies during his career because of conflict with superiors and emotional abuse of co-workers. So let's see what your diagnoses are. Moderate with anancastia, severe PD, anancastia dissociality, moderate PD. Anyone else? Because we have moderate and severe and anancastia and dissociality. Anyone else wants to give any other? Okay. Thank you.
There are a few more responses.
Okay. Okay. Let me see the responses first. Anancastic, moderate PD, and anancastia, negative affectivity. Okay. So he has moderate PD because he has compromised capacity for understanding and appreciating others' perspective. His work relationships are disrupted, so interpersonal problems are there. Persistent conflicts result in emotional harm to others, and he has a sense of entitlement. So his self-appraisal is problematic. So there is a self issue and there is the interpersonal issues. He's an anancastic because of stubbornness, desire for orderliness and perfectionism. He's dissocial in the sense of he has some amount of grandiosity, entitlement. He lacks empathy for others, can be mean and hostile to other people. Severe personality disorder is ruled out because his work productivity is reasonably good. He was able to maintain some relationship for certain periods of time. Mild PD is ruled out because he is incapable of or unwilling to sustain employment. He leaves his employment, is not thrown out in that sense due to interpersonal issues, does not have any positive or healthy relationship, including family. So the problems are more than mild and they seem to be less than severe in that case. So basically, if you look at ICD-11, it seems like a new system, but the once you start applying it, it should not be very difficult to apply it. So this was the feedback that I wanted to discuss, and thank you everyone for patiently listening to a longish monologue.
Thank you very much, sir. And I would like to request Professor Chadha sir to give his concluding remarks.
I think we had a very interactive session with the very active response from so many of participants, and we had a large group of participants going who had joined online. It was nearly more 80 people who had joined. So I think this is a very encouraging sign, and would like to thank NAMS and all the participants, and I'll request Dr. Sood from NAMS to conclude the session.
Thank you, sir. Thank you so much. It is my great pleasure to thank the eminent expert for this evening who have made this session so productive, so useful for the student. The fact that so many questions have been asked, that itself shows that the students have definitely liked this session. The practical tips which has been given are useful to them. I would like to thank the speaker for this evening, Professor Pratap Sharan sir, for making this topic so comprehensively and simple for the students. So thank you so much, sir. We look forward for your support in future also. A great thanks to Professor Rakesh Chadha sir for planning this series of lecture and identifying the topics as well as the speakers. So we are really thankful to you for your support. You have been always great support as a council member, but here again, you have been present throughout the 2-hour session. So thank you so much, sir, for your support. I'm sure that the students with your presence have not only learned, but also they have felt encouragement. And that is what very, very important for the PG student. So once again, I will like to thank all the PG students who have made this session interactive by asking questions. And once again, I would like to make appeal to all the PG students that they should take the best use of this opportunity. See, you have the topmost experts who are interacting with you. They are spending nearly 2 hours with you. So it is, I think, really a good chance for you to clarify your doubts and interact with them. This is a great opportunity. Please use that. Now, as far as the Navigate CME is concerned, we have circulated you 5 e-brochures, which are going to cover the main themes. In the month of May, we are going to cover 2 themes. First, leftover 2 sessions from the management of hepatic disorders, which we are going to cover on Tuesdays, and 2 sessions from psychiatric problem we are going to cover in the month of May, and rest of the session we are going to cover in the month of June. So I will just like to remind you that the next session for the psychiatry session is due on 25th of May, and where we are going to cover another very interesting topic of autism. And again, very eminent speaker is going to interact with you. So in case you have any questions, please write to us in advance. We'll try to send it to the speaker so that they can be covered. As far as the series on liver problem, hepatic problem is concerned, I just want to remind you that these sessions are held on Tuesdays, and the next session is due on 23rd of May, and the last session in the series is on 30th of May. The 23rd May session, that is the next Tuesday, we are going to cover management of ascites. With these words, I will again like to request all the PG students, please tell your friends, tell your colleagues to attend this session in large number and get the benefit of a discussion and interaction with the topmost expert in the country. I will also like to thank Dr. Preeti for helping us throughout this series right from the month of January 2000 this year. And she always has been great support to us. So thank you so much for moderating and conducting the session so smoothly. In the end, I will also like to praise the help which has been provided by the IT unit of our names, Mr. Ravi and Mr. Anil. So with these words, once again, I will like to thank all the eminent speaker as well as the students who have made this session so interactive and useful. Thank you so much. See you on the next session, which is due on next 25th of May on next Thursday. With these words, I again want to thank you all.
Thank you, sir. Thank you all. So I would now like to say that today's academic session is closed. Thank you.